Okay. So the purpose of this webinar is to really give people an overview about the implicit network, introducing our two models of care, ICC and fourth trimester, and kind of for people joining us who are potential new sites interested in joining the network and implementing ICC, explaining that process and what the steps are to join the implicit network. So we just want to be mindful as a network of utilizing gender inclusive language. It is something that we are trying very hard as a network to do, and we are not perfect at it. Our goal is to utilize women slash birthing people or mother slash birthing person or mothers slash birthing people when we are talking about people who are giving birth, and then also trying to utilize pregnancy and perinatal care. We are still a work in progress, so apologies if we do slip up. So just quickly, because I forgot to introduce myself, my name is Anna Federoff. I am the Implicit Network Manager. And then the mission of the Implicit Network is a learning collaborative focus on improving birth outcomes and promoting the health of women, birthing people, infants, and families through innovative models of care and quality improvement and professional development for current and future physicians. And then these are our values that we try to recognize in our everyday work and to work towards achieving in what we're doing. So why is the implicit network important? Why is the work that we're doing important? I don't think I have to belabor the point that our maternal mortality morbidity rates are not great in the United States and have unfortunately continued to rise. And you can see we have nearly doubled since 2018, and that is 32.9 out of 100,000 for our total birthing people. But if you look at people within minorities like our Black population, the disparity is so much higher than our white counterparts. With that, we also have high preterm birth rates in our country. As a country, the March of Dimes gives us a D+ as a report. So we definitely have a lot of work to do with seeing more and more maternity care deserts appear in the United States. So what we're doing within Implicit is really trying to change this narrative. So who is the Implicit Network? So Implicit stands for Interventions to Minimize Preterm and Low Birth Weight Infants Using Continuous Improvement Techniques. As the network was established in 2003, kind of our focus was on our interconception care model and addressing preterm and low birth weight infants. As we have continued to grow as a network, we now also are really working with improving maternal mortality outcomes as well. So our network is developing, implementing, evaluating, and optimizing new models of care to work on improving these birth outcomes and improving the health of women and birthing people. We support our sites in implementation of ICC and fourth trimester models. And we also provide a space as a learning collaborative to provide evidence on our models and resource trainings and support for providers, faculty, residents, medical students, and clinical staff. We also then create a professional forum to really have our sites and our providers be able to collaborate, have conversations, do scholarly work, and come together to continue the work that a lot of our providers are really passionate about in the reproductive landscape. So the Implicit Network is historically has had 51 sites across 12 states implement ICC. Currently, we are active in 44 sites, and out of those 44 sites, 29 are sharing data with us with our REDCap system, and 12 of those 44 sites are active with fourth trimester in addition to ICC. So now that we've had a little bit of background about the network, we're going to jump into what is ICC and what is fourth trimester. So I'm going to hand it over to Amy Smith.
Okay. Hi, I'm Amy Smith. I am a family medicine osteopathic physician in the Mid-Hudson Valley region in New York. I've been working with the IMPLICIT network since 2007 when I was a resident. Can you go to the next slide, Anna? So why ICC? We actually, when we started as a network in 2003, did not start with ICC. We started with a prenatal intervention. And what we found with a couple years of research and CQI was that by the time women presented for prenatal care, most of their risk was pretty set by then. And it was really hard to make any substantive change in the outcomes. So we started the Interconception Care Project to try and target women between pregnancies, and it allows us to identify and address risk factors prior to their next planned pregnancy. About 1 in 10 infants in the United States are born prematurely, and about 52% of non-Hispanic Black women are more likely to experience premature birth as compared to their white counterparts. Next slide, please. So interconception care is a brief, innovative model that screens mothers birthing people at well-child visits from birth to 2 years old and addresses 4 modifiable risk factors. We screen for smoking, depression, family planning, and prenatal and multivitamin use. Before we started this project, we did a primary study to see if women would be open to this, and 94% of birthing people attended their child's well-child visit. About 93% reported that they would be willing to receive health advice from their child's doctor. And about 64% of women in that initial survey screened positive for 1 or more risk factors during the well-child visit. Next slide. So smoking during pregnancy is associated with an increased risk of preterm births, as well as infant growth restriction, preterm related deaths, and an increase in sudden infant death syndrome. So even though we are doing this to plan for their next pregnancy, all of these have impacts on the current child and family as well, which is how we're able to document in the current child's chart. Folic acid is recommended for up to a year before a planned pregnancy and helps reduce neural tube defects and preterm deliveries. 1 in 8 women is affected by perinatal depression. Major depression peaks about 6 weeks after birth, but can occur at any time between pregnancies. And the recommended spacing between pregnancies is about 18 months. And if most women do not present for a preconception planning visit, but they do bring their children in for their visits. So next slide. So our model and rationale is that women will bring their children in for their well visits, even though they often don't seek care for themselves. Their health will directly impact their child's health, both positively and negatively. And most women are open to accepting advice about their own health at their pediatric visits. Next slide. So we focused on the 4 evidence-based risk factors that can affect future birth outcomes. And the screens are recommended to be completed at every well-child visit from birth to 2 years. At each visit, we would screen and support the birthing persons. If they screen positive for any of the risk factors, we have multiple interventions that can be used. And one of the things that we work with each site with is helping set up those workflows for each office. Over the years, we've had about 48,000 unique dyads with over 200,000 well-child visits. About 95% of them mom is present at, and about, excuse me, we have about an 88% screening rate. We have fairly high risk rates in our populations. We are spread, as you saw from the map, we're spread all over the eastern seaboard and starting to edge into the middle of the country. We have very disparate sites. Some of these are huge residency sites. Some of these are tiny, tiny little offices. We have a couple pediatric sites as well. But our average risk rates for smoking are about 12.5%. Depression is about 6%. Family planning, which we would look at as not having a plan, is positive screen about 30% of the time. And about 44% of our patients aren't taking a multivitamin with folic acid. And we have differing intervention rates for all of those positive screens. We have an intervention spectrum for each of these if they screen positive. So depending on which site you're working at, sometimes if you're at a family medicine site, the birthing person is also your patient, and you can easily have a direct impact on their care. Sometimes they are not our patients. And then at our pediatric sites, none of them are patients of the practice. So we go all the way from, you're cheating, Hannah. We go all the way from directly treating the patient in the visit, or in most places, they quickly create a second visit for the birthing person, or just giving them information on local resources and talking about why it's a risk and helping them with a referral at some places. So now you can go to the next slide. We also have a bunch of patient education that is available. Most of our sites will take something like this and either use it directly, or you can modify it to fit your site so that you can have very easy interventions that are very quick to use. Most of the time, these screenings take less than 3 minutes. I think that's it for mine.
All right, and I'm going to talk a little bit about the fourth trimester. My name is Brianna Moyer. I am faculty at the Penn Medicine Lancaster General Family Medicine Residency Program, and I am one of the implicit provider champions there. And our fourth trimester program really focuses on screening for risk factors during pregnancy and then addressing those in the early postpartum period. So really, this model came out of ACOG's call for a new paradigm for postpartum care in their committee opinion in 2018, where they recommended that all birthing people be seen within 3 weeks of delivery by their prenatal care providers. And this certainly comes in the light of knowing that we have a very high rate of morbidity and mortality in the postpartum period and in women and birthing people in general in the United States. Next slide. So this model, the fourth trimester model, really aims to address the current needs of women and birthing people and protect against that morbidity and mortality, and just to kind of recognize some of those things that we know women and birthing people experience. We know that over 50% of postpartum strokes occur after the birth of the baby, so within 10 days of discharge. Over 50% of pregnancy-related deaths occur after birth. We know that there are many social, physical, and psychological changes and challenges that birthing people experience. And unfortunately, as many as 40% of women and birthing people in our country do not attend a postpartum visit. And when they do attend a postpartum visit, it often is in the setting of very fragmented care, where they may be seeing one provider for that postpartum visit, but not having follow-up or not good communication with their primary care provider. And so there's that fragmented model without good follow-up moving forward. Next slide. So really what this model is aiming to do is, number one, identify women or birthing people who are high risk by screening during the pregnancy for those risk factors, so that that kind of care model and that support system can be built even before the delivery of the baby. We also are aiming to provide postpartum care and have a visit for all women and birthing people within 3 weeks of giving birth. So really sticking to that recommendation by ACOG and making that a standard that all birthing people are seeing for an early visit. And then finally, the third aim is to really enhance care delivery and establish a care team so that we kind of reduce that fragmented care and have a care home for these patients moving forward. Slide. So what this looks like right now is specific times during the prenatal and postpartum period where we're doing screening, and just really remembering that this is a care model, not just a time period, not just a certain number of weeks after delivery, but an ongoing care model. So we are doing 3 specific questionnaires or screening tools. The first one is happening around the 36-week visit, so sometime in the 3rd trimester. And this is to identify pre-existing conditions, identify risk factors, and come up with a plan for the postpartum period. Then the second screening is happening at the time of hospital discharge, so usually 2 to 3 days after birth. This is identifying any new risks or complications that occurred during the delivery and making sure there's a clear plan for follow-up and a clear communication with the outpatient team. And then the third screening is happening at an early postpartum visit. So every birthing person is being scheduled for a visit within 3 weeks of delivery. And at that time, we're assessing for biomedical or psychosocial risks, providing any support services that are indicated, and following up on that postpartum plan to make sure that the patient is receiving the care they want to receive. And then this is also including kind of the routine or that standard postpartum visit that was traditionally happening at 6 to 8 weeks after delivery. And then at that point, following up on all the things that were identified earlier on, but also making sure there is a clear plan moving forward in terms of connecting with primary care, whether that's, something we do through our own office if we are primary care offices, or if we're connecting with a different primary care provider for the patient. Next slide. So these questionnaires that we're using are using standardized questions to screen for risk factors, and these are some of the things that are included. So we're asking about delivery method, both in the prenatal period, asking about the intended delivery method, whether it be a scheduled C-section or planned vaginal delivery or TOLAC, trial of labor after cesarean, and then also recording what actually was the delivery method. We're assessing for biomedical risks at all of these periods, both in the prenatal, at the time of discharge from the hospital, and then at the early postpartum visit. Reviewing prior birth complications or trauma that may factor into the current pregnancy, asking about smoking, vaping, substance use, talking about family planning, both what is the intention and then what actually happens in the early postpartum period. Again, talking about feeding intention and the current status, mood disorders, intimate partner violence, neonatal outcomes, any new symptoms, and then really making sure we have a plan for follow-up and that we're identifying any support services that are needed and connecting patients with those. Next question. So a lot of questions often come up about billing and are these visits billable, because this model is suggesting at least a minimum of 2 postpartum visits. So that early visit within 3 weeks of delivery, and then that 6 to 8 week postpartum visit. And the answer from the sites that are doing this is yes, these visits are billable. The way that this is being done, that most insurance companies are covering, is by billing that early postpartum visit as a problem-based visit. So like our problem-based codes, like a 99213 or a 99214, and we're using diagnoses based on any risk factors. So for example, if we have a patient who had preeclampsia or a patient with diabetes, depression, obesity, etc., we are finding that there's almost always something to talk about, even if it is not a significant biomedical complication. It may be something like difficulty with breastfeeding, breast soreness, etc. So any of those diagnoses can count, and it can be used as a problem-based visit. And then that comprehensive postpartum visit that's happening at 6 to 8 weeks, we're billing kind of under our bundled payment for the OB or prenatal care if we were the providers providing that. So we are getting reimbursed for these early visits. And the other thing I should mention is every site's kind of doing this a little bit differently in terms of the timing, but many of our sites are family practice sites that are doing dyad visits. And so we are really trying to schedule birthing people and their babies on the same day. So for example, we will do that early postpartum visit at a 2-week visit where we're also doing a weight check for the baby so that the baby is scheduled the same day as the birthing person for separate appointments with the same provider. And then at that 6 to 8 week postpartum visit, we're scheduling that at the same time as the 2-month well child check so that the birthing person and the baby can be seen on the same day with their own appointments. This is just some data from all of our sites that are currently doing this 4th trimester model. This data is from January 2022 through September 2024. And what it's showing you is when did that early postpartum visit happen in relation to the birth. So the first column is saying, did we have a visit? Was it within 1 week of the birth? 1 to 3 weeks is the next column, and then greater than 3 weeks is the third column. The fourth column is we're just not sure when, and then the last column is they did not have any type of postpartum visit. So what we're seeing here is that we have over 50%, close to 60% of patients coming in within 3 weeks of delivery with this model, and then 70% of patients being seen for postpartum care, which knowing that kind of national statistics are that 40% of patients do not get any type of postpartum care, this is showing that we're having improvement compared to that rate in terms of the number of patients being seen. And then certainly we've shifted it towards having patients seen for earlier visits, which we're very encouraged by this initial data.
Thank you very much. So now that we have talked about what ICC is and what 4th trimester is, we'll go through a how as a network we help you implement. So kind of the first thing is really identifying your team. So the most success that you can have at a site really depends on the buy-in at your site. So we identify a site or provider champion. It does not have to be a MD or DO. It can be a nurse practitioner or a physician assistant. We have some nurse champions as well. So this is the person that is kind of our point of contact with your site and that our team works closely with. Once you have designated that person, is we kind of build out your support team. So that can include other providers, advanced practitioners, nurses, pharmacists. If you have behavioral health services at your site, that can also be included. We also, some sites have IT members on their support team, which is really crucial when building the questionnaires into your EMR. The other thing is really getting your front office staff, office managers involved as well, because it can be a process that goes from check-in to through patient care. So making sure that everyone in the office really is in on the same page and supporting this is the best way to be successful. It is also a great place to, if you are a academic site, to have residents, medical assistants, medical students involved. We do collect a lot of data, and that is a great opportunity for QI projects for different residents and medical students. The other big part is really the support from IT. We know IT and building things into EMRs tends to be the longest time. So if we can build that relationship, that is a very important part of building your team as well. Each site is required to obtain an IRB. as a network, we do have example IRBs that you're able to work off of. And this is a great part of being a part of the implicit network, is not having to reinvent the wheel. So you would utilize one of these previously written ones and tailor it to your site and your needs. But once that IRB is submitted, all of our sites have received exemption because ICC and fourth trimester are not research. It is a quality improvement project. Even if you are a site sharing data, all of our data shared is de-identified. So once you submit that IRB, it is 9 times out of 10, it is exempt, so we don't have an issue moving forward. It is just one stepping stone that we have to complete, though. Developing workflows is kind of the next. Each site is different in how they implement. We have some sites that are fully manual, so they hand out a hard copy of the questionnaire that the patient fills out. The provider then fills their interventions out on that same copy, and someone is entering that data in manually. Then we have some sites that are fully automated, where the patient is given the questionnaire on like an iPad, that it then flows into the child's chart, so the provider can click through the interventions in the chart, and at the end of the month a report is sent out or is created that has the data that then is uploaded into REDCap. So we work with your site on what your site requires for your workflow. If you're unable to build it into the EHR right away, we start manually, but we're always constantly working with you on how best to create this workflow and what works best for you. And also, successful models really don't just rely on the physician. We know that when the provider is going into the room to do a visit, they have less than 15 minutes to cover everything. So having things like the questionnaire already completed is something that is very helpful. And we have examples of different sites and how they complete this. So really being able to utilize that and share that with those sites. So we work with you to create a custom workflow, and that may include things like having your material in different languages that are relevant to your site's population. So ICC and fourth trimester is continuous quality improvement. So once implementation happens, that's not it. We're not done. We want to really make sure that this is becoming standard of care, that we are helping you identify areas of improvement, and where you're having successes and where you could improve. So we have regular meetings with a team member. So either myself or we have 2 Pennsylvania coordinators. We identify your data where you may have screening or intervention issues. So we're looking at your data on a regular basis. And then helping create PDSA cycles for quality improvement. So within this, you also can utilize your data for things like scholarly projects, or have residents do a quality improvement project where maybe they want to focus on improving smoking at your site. So they specifically work on that and utilize their data to show improvement with what their intervention was for that cycle. So just some final thoughts. So becoming a network member. So we've talked about some of this stuff, but here are some of the benefits. So coordinator support, that is support through implementation. So having a site buy-in meeting, not just with your core team, but also with your whole site, helping you build those screening and data workflows, providing training and education. Like Amy said, we can help provide site-specific educational materials with resources for specific risk factors that are relevant to your area. And then helping with EHR build. So we do have a national build in Epic for ICC, and we are currently working on having a national build for fourth trimester in Epic as well. But we also work with sites that have other EHRs such as Allscripts or Cerner. We also will provide you quarterly or monthly data reports depending on your site's needs, and helping you create CQI or PDSA cycles. We, as a network, will normally focus on one about every 2 years to try to improve network items. So that may be something. Our recent one was really focusing on switching our mentality of contraception to family planning with a very patient-centered approach. So providing education and resources and looking at our data during that. We also help provide collaboration on publications and conference submissions with our data being a part of the network. And if you are sharing data, you then have access to our network data. And then you also have access to all of our material, whether some of our historical stuff, implementation. We also have presentations that you can utilize. We do provide communication, including biannual newsletters. And we are housing the data in our REDCap system. So we house that, and we have a biostatistician who creates a reporting mechanism so that we can look at our data in a clean version. And then we do have at least 3 webinars a year and 2 annual meetings. So one in the fall, which is in person and connected with the FMEC meeting. And then one is a spring meeting, which will always have a virtual option. And then we do have 3 committees within our network: the Data Review Committee, Scholarly Activity, and Health Equity Committees. These committees, anyone who's a member of the network can be a part of, and are great opportunities to really dive a little bit deeper. They are not required. You're not required if you attend one to attend them all, but our opportunities where our data review committee sometimes is suggesting and making changes on how we're asking our questions, or our scholarly activity is helping push forward our publications. Another big thing I alluded to earlier is the applicability of medical student and resident education. So we are at over 20 family medicine residency sites. So we offer and help with training for residents on these new standard of care models to help integrate in future practices. So we have members of our network who started out with us when they were residents and are now provider champions at their own sites. We also help collaborate on QI projects with medical students and residents, and really help if they want to submit posters or presentations to conferences, and supporting publication works as well. So some key takeaways: the Implicit Network has successfully integrated innovative care models into primary care settings, and we are continuing to do that. We have an adaptive model and the support to help you implement in what works for your site, and are flexible in working with you to meet your site's needs. We have a plethora of resources available to help with implementation and also continuing education. So as a network, we are really there to try to foster collaboration, learning, QI, and just moving forward a new model of care. So if you're interested in joining the network, I know we have some people who are potentially interested. We would love to chat with you further. We do have a ICC toolkit, which is on the March of Dimes website, so you can access that here with that QR code. And then we also currently have a page on the FMEC website, and we do have an Instagram. So at this time, I would like to provide an opportunity for people to ask questions. Let me just stop sharing. All right. Do we have any questions?
This is Gordana with the Illinois Academy of Family Physicians. I